I'm Steve Flockey. I'm an Associate Director of the Prevention Research Center for Health in Neighborhoods. I'd like to welcome you to our seminar series. This is our monthly series to present research and findings around prevention and health promotion. Today we've got a guest speaker. And before I introduce Darcy, who's going to introduce our guest speaker, I just want to remind you about the schedule that's coming up. We do have a couple of modifications. We'll try to have the updates on the website. But next month, you're going to be hearing from a team that's working on measuring nicotine dependence. We're actually going to, among cigarillo users, we're actually going to do that as a panel presentation. And we're pretty excited to share some of the findings that we have from that study. And so that's a modification for January. We're also working on the possibility of having another outside guest speaker come in May. So stay tuned for that. We'll share details as we get them. If you've got suggestions or topic ideas or just want to provide us feedback, go ahead and send that email to me. We'd love to hear from you. And also, if you have not signed in, please do that. We've got a sign-in sheet so we can just track who's here, who's coming, who we're reaching, and also use that as a vehicle to let you know about other upcoming seminars, as well as other activities that are going on, sponsored by the Prevention Research Center that you may be interested in. If you enjoy this, please do share it with your friends and colleagues. This is free and open to everyone, and we're delighted to be able to provide a light lunch for you, and so that you can really enjoy the presentation. So with that, I'd like to introduce Darcy Flanagan, also Associate Director of Prevention Research Center, who will introduce our speaker.
Okay, thank you. And thank you guys for being here. I'm excited to introduce Dr. Laura Samuel. Dr. Samuel is Assistant Professor at Johns Hopkins School of Nursing. She also is affiliated with the Center on Aging and Health and the Center in Innovative Care and Aging. Dr. Samuel was a nurse practitioner prior to her status now as a faculty member at the university, and brings to her research a lot of experiences working with patients, seeing the complex ways that all of these factors interact and contribute to health. And I think shifting where are the interventions and possibly being at the level of policy as one strategy or one solution. So super excited to have Dr. Samuel here. Following the seminar today from 1:30 to 3:30, we are having a smaller group discussion about the role of research in Farm Bill advocacy. If you're interested in staying on, it will be here 1:30 to 3:30, and that session will be co-hosted by the Cleveland-Tyler County Food Policy Coalition. So, thank you.
Thank you. So, thank you all for coming, and I have slides prepared that will talk about some of the research that I've done and am still doing related to the health effects of SNAP, the Supplemental Nutrition Assistance Program. But I hope that you feel free to interrupt with questions along the way, too. So, as a bit of background, a lot of my work has dealt with health outcomes for older adults. I'm broadly interested in socioeconomic disparities related to aging, and most of the research that I've done so far has really focused on the health outcomes for older adults, including functional health outcomes, chronic conditions, and the healthcare utilization. And so I'm interested in SNAP because it provides a mechanism, potentially, for improving health outcomes for this vulnerable group, right? And it provides money that can be directly applied for food, and we know that food is important to maintain health and manage chronic conditions. And so a lot of my work looks at the subpopulation of low-income individuals. About 1/3 of older adults would classify as low-income, meaning they're about below the 200% poverty threshold. And this group of people utilize more hospital-based healthcare services. There's some really good evidence to show that. There's a lot of what we call preventable hospitalizations in this population. They also probably are more likely to be admitted to the nursing home, although there's not really good data to justify that statement that I just made. But we know that they have generally really poor health outcomes otherwise, including high rates of disability and functional limitations, and those tend to be the reasons why older adults go into the nursing home. So this is a vulnerable group. They tend to have fairly high rates of food insecurity, right? So I assume I don't need to define food insecurity to this group, but just in case, kind of the inability to provide for sufficient amounts of food on a regular basis. So 4.8 million older adults experience food insecurity. A lot of those people are low-income individuals. And food insecure adults have limitations in activities of daily living that are comparable to older adults who are 14 years older than them, right? So for example, activities of daily living, including things like brushing your teeth and getting dressed and cooking for yourself, these kind of common daily activities. And these people just tend to age faster. Their ability to take care of themselves is comparable to someone who's 14 years older than them. We also know that food insecurity is associated with lots of other adverse health outcomes, including poor dietary quality, higher rates of chronic diseases, and there's some good evidence to suggest even that as income gets depleted over the course of the month within a household, that low-income individuals are more likely to be hospitalized for hypoglycemia as well. And we see a similar trend related to dietary patterns, where they're more likely to go hungry at the end of the month. And so this food insecurity might have, therefore, significant health implications. And I bring this up related to food insecurity because SNAP has really been shown to influence, whoops, I went backwards. That's not what I intended to do. Oh, there's the laser. Okay. So SNAP reduces food insecurity. There's really good evidence to show that people who become enrolled in SNAP or newly participate in SNAP are less likely to be food insecure after that. But we know that not everybody who could benefit from SNAP actually participates in SNAP. So in households where there are children, there are very good rates of participation, but the same is not true for older adults. Only about 42% of older adults who would be eligible for SNAP by virtue of their low-income status actually utilize the benefit. And one way that we can therefore figure out whether SNAP could improve health is by comparing people who utilize the benefit to those who don't. And that's what you'll see here today. And the reason why we did that is because the effect on healthcare utilization is not really clear. So there have been a couple of studies that have tested whether SNAP participation is associated with reduced healthcare utilization. One study used population-level data from Massachusetts after the SNAP benefit increase, so the ARRA, or the American Recovery and Reinvestment Act, increased SNAP eligibility and benefit amounts. And in Massachusetts, they used hospital inpatient cost data to see if the hospital costs decreased after that change, after that influx of money into the SNAP program. And they did actually see that there was a decline in the growth. So costs continued to rise, but there seemed to be at least some change in 2009 when that new SNAP money came in, where the growth was at least muted or attenuated a little bit. There also is some evidence, however, from a very large national sample of older adults that showed that SNAP participants actually had a higher risk of hospitalization than their peers. So that's not what we had hypothesized, right? And one of the challenges is that people who participate in SNAP might be kind of self-selecting in. They might participate in SNAP because they're sicker or because they have fewer financial resources or they don't have other places to turn, right? And so this self-selection into SNAP is methodologically a challenging problem, right, that you kind of need to deal with. And the other challenge with this study in particular is that they actually adjusted for people's ability to manage their diabetes. This is among a sample, I should say, of diabetic older adults, not just all older adults. Sorry, I left that point out. And so these people actually, the study adjusted for their ability to manage their diabetes. And it might have actually over-adjusted, therefore, because SNAP might actually improve health by improving your ability to manage diabetes, right? And therefore, they might have kind of over-adjusted the model. So we wanted to see if we could actually find any association between SNAP participation and healthcare utilization in a low-income population. So we had two key hypotheses. One was that SNAP participation would be associated with reduced hospital and nursing home utilization during the subsequent year, and that greater SNAP benefit amounts would be associated with reduced hospital and nursing home utilization among SNAP participants during the next year, right? So kind of two ideas. We're comparing SNAP participants to non-participants, and then secondly, among people who all participate in SNAP, we want to know if greater benefit amounts appear to have a protective effect as well, okay? And the reason why we looked at the second one is that we're not as concerned about that self-selection effect biasing the results, right? We're comparing all people who have already selected in the SNAP, who all participate in SNAP, to see if simply benefit amounts are correlated with health outcomes. And in general, higher benefit amounts are given to people who have lower income levels. And so these are actually probably more vulnerable people. So if you can actually see an association between benefit amount and health outcomes, it's actually probably stronger evidence to support the idea that SNAP might actually have some health effect, okay? So the way that we did this is that we had a unique partnership that was kind of facilitated by Benefits Data Trust, an organization Rachel Cahill here used to work for. And they had a relationship already with the state of Maryland. And we were able to, by virtue of these relationships with State Department of Human Resources and the Department of Health and Mental Hygiene, we were able to get access to SNAP data and link it with Medicaid data and Medicare data. Now, the Medicare data was housed at Hilltop, and they did all of the actual data merging, management, and analyses because of their relationship with the state. They're part of the University of Maryland system, so they have a contract to use some of these state data sets already and had access to it. And so this data set was really a very unique opportunity to get data on all Maryland dually eligible adults. So these are adults who are eligible not just for Medicare but for Medicaid. And if they're eligible for Medicaid, we know that they're all low income, right? So it's a low income population. And it was all of the older adults from 2009 to 2012. So it's not a sample, it's really a true population. And so we could really leverage this data to ask some interesting questions. And I don't, frankly, know of any other data sets out there that are similar to this in terms of having the ability to look at actual SNAP benefit amounts, enrollment dates, and really kind of quantify participation that way. So the population, as I said, was Maryland adults who were 65 years and older who were enrolled in both Medicare and Medicaid. Our outcomes were measured from 2010 to 2012. And so we included each year of data for each person. If the person was enrolled in the fee-for-service Medicare, we excluded people who were enrolled in Medicare Advantage because we don't have access to their claims data. That's held privately. And we excluded people who either enrolled or died during the year and had less than 6 months of data because we felt like that wouldn't be a sufficient amount of time during the year to know whether or not they utilized a hospital or nursing home service. So as I said, the outcomes were calculated for each year from 2010 to 2012. The outcomes included hospital utilization and nursing home utilization. So for hospital utilization, we had the number of days that an individual was in the hospital. We had the number of emergency department visits, and we had the cost for inpatient hospitalization. For nursing home utilization, we had the annual count of nursing home days and the annual cost for nursing home admission. So we were able to really look at these 5 outcomes then, 3 related to hospitalization and 2 related to nursing home. And our SNAP exposure was measured in 2 separate ways. So as I said, remember I had 2 separate hypotheses. We compared participants to non-participants. And so we were able to assess whether or not somebody participated in SNAP in any given year. And that was measured from 2009 to 2012 because we wanted to know about, so we were regressing each year's healthcare utilization on their prior year's participation in SNAP, so we had a lagged effect. And then among SNAP participants, we also were able to capture their average monthly benefit amount in $10 increments for those same years. Any questions so far in terms of the method for searching? Okay. Yeah.
Did you include comorbidity information?
We did.
Okay.
Yeah.
I think we're coming to it. Never mind.
Yeah. This is a great segue, though. Thank you for that. We're getting there.
Anytime.
Thanks. So we regressed annual healthcare utilization outcomes. Those 5 separate outcomes were analyzed in separate models, and they were each regressed on the prior year SNAP participation. And among participants, we also looked at the benefit amount as an exposure. And so these, the hospital admission, nursing home admission, and emergency department utilization were examined using zero-inflated negative binomial models with robust standard errors. So these are models that can account for the large frequency of zeros, right? A lot of people don't get admitted at all to the hospital or nursing home. And so we could account for the fact that these models would naturally be well suited to that type of data, where there's a lot of people who are not admitted, and then some people who have a large number of days either in the hospital or nursing home, so it's very skewed data. And then the nursing home and hospital cost data were examined using Heckman models, which economists typically use to similar kind of 2-stage models to examine first whether or not somebody had costs for either of those sources of health care. And then among the people who had some cost for either hospitalization or nursing home admission, you could look at the amount of cost. So it's a similar idea to the negative binomial model. And all of the regression models adjusted for sex, race, age, income level, chronic conditions, enrollment in the Medicaid Community Waiver Program, which allows older adults to age in their place, age in place in their home if they have a physical disability. We adjusted for category of Medicaid enrollment, such as partial eligibility versus full eligibility. A study year, we accounted for autoregressive effects, right? So if somebody was admitted now, it might be in part, if somebody was admitted now, they might be more likely to also be admitted in the next year. And we accounted for, and we looked at the cumulative monthly average lag SNAP amount in the benefit amount model, and we also accounted for each year's SNAP participation in the SNAP participation model. So it's just their average benefit amount from the prior year. That's all we mean by lagged. So you regress their 2012 hospitalization on the 2011 benefit amount, for example, right? Assuming that the SNAP benefit would
what affected current behavior
affect, right, their future health outcomes. Okay, so this is a summary of the population. We had data for almost 70,000 older adults in Maryland. The average income was very, very low, right? So this is really probably below the poverty limit. The average annual household income was around $5,800. The sample was predominantly female, which is typical for low-income older adults because women last longer than men on average. And they typically had at least 2 chronic conditions, and only 47% of them were enrolled in SNAP. This is comparable to national data, which has shown that about 42% of low-income older adults benefit from SNAP. And among those who received it, the average monthly benefit was $117. And I say that because this is actually a sizable amount of money when you consider what their annual income was, right? So SNAP can provide a large amount of support for an individual in a low-income household, right? So a monthly benefit of $100 even would be $1,200 over the year. And if you're only earning $5,800, $1,200 would support a large portion of your food budget, right, and make a sizable difference in terms of your ability probably to maintain your health. Okay, so these are the results for nursing home utilization. So again, these were a couple of different models. The first model looked at SNAP participation, And we found that SNAP participants had a 23% lower odds of being admitted to the nursing home in the next year. And that among those who were admitted, SNAP participants had an 8% reduced likelihood of having each additional subsequent day. So they had shorter stays in the hospital compared to non-participants. And then among people who participate in the program, again, we looked at them to see whether the monthly amount was also associated with healthcare utilization. And we could see here that a $10 increase in the monthly SNAP amount was associated with a 7% reduced odds of nursing home admission in the subsequent year. And then among those who were admitted to the nursing home, additional higher levels of SNAP benefits were also associated with shorter stays. So every $10 increase in SNAP is associated with 1% reduced likelihood for each additional day in the nursing home, suggesting that greater benefit amounts were actually associated not only with reduced admissions, but also with shorter stays among those who were admitted. And so based on our regression models, we were able to work with some economists at Northwestern to estimate the potential cost savings that would be associated with both the reduced admissions and the shorter stays, comparing participants to non-participants. As we said, only 47% of our older adults participated. In Maryland, anybody who's below 200% is, and an older adult is eligible for SNAP. So all of these people should have been eligible for SNAP by virtue of being eligible for Medicaid. Of course, there are some, that's kind of a broad statement. There are some restrictions related to assets and things like that. But in general, all of them should have been eligible for SNAP. And so if you could enroll these 25,000 people in our 2012 data who were not receiving SNAP benefits, if we could enroll them, we estimate based on our regression models that you would save almost $19 million annually from averted nursing home admissions. And you would save an additional $15 million from having shorter, less costly stays. And so overall, this would translate into a potential savings of over $34 million annually related to less nursing home costs. And now I'm going to talk a little bit about our hospital results. So we also looked at, as I said, hospital-related outcomes. And so what we see here is that SNAP participants had a 14% reduced odds of being admitted to the hospital compared to non-participants. And that among those who were admitted to the hospital, SNAP participants had a 10% lower likelihood of having each additional day in the hospital, suggesting that SNAP participation is associated not only with reduced likelihood of being admitted to the hospital, but also with shorter stays in the hospital. And that among people who received SNAP benefits, we also saw that higher benefit amounts is associated with a slightly reduced odds of being admitted and lower likelihood of having each additional day in the hospital. Again, suggesting that these higher benefit amounts are associated with reduced likelihood of hospitalization in the subsequent year and shorter stays if they do get admitted. And then we also looked at emergency department utilization, and we found pretty similar results. So SNAP participants had a 10% reduced odds of using the emergency department at all, and among those who did utilize the emergency department, they had a 4% likelihood, a 4% lower likelihood of having each additional emergency department visit. And likewise, among SNAP participants, each additional $10 increase was associated with a 2% odds of using the emergency department at all, and a 1% reduced likelihood of using it among the emergency department users for each additional visit. So overall, this suggests that SNAP participation and greater benefit amounts predict lower utilization for both nursing home and hospital care. Right? And related to this, you would also expect to see a significant potential cost savings. So we estimated the cost savings that could be expected attributable to reduced hospital-based utilization. And what we see here, again, using our data and estimating the potential cost savings from enrolling these 25,000 non-participating older adults, we suspect that there would be about $9 million saved annually related to averted hospital admissions, and about $9.7 million attributable to less costly stays among those who are admitted to the hospital. And again, this is assuming that you could enroll these SNAP non-participants into the SNAP program. But in total, you would expect to see about a $19 million cost savings attributable to reduced hospital costs. And this is just inpatient hospital care. We can't really, based on the data that we have, we can't really estimate the cost savings that would be attributable to the emergency department utilization. And so the data that you've seen is really just the estimated cost savings related to inpatient nursing home and inpatient hospital care. But together, it's a pretty sizable amount. And so to summarize our results, we saw that SNAP participation predicted less healthcare utilization in the following year, lower odds of nursing home admission, lower odds of hospital admission, and lower odds of using the emergency department. And this is informative because low-income people, as I said earlier, are very reliant on these services, more so than their higher-income peers. And among those who are admitted, SNAP participants had shorter stays. They were less likely to stay for each additional subsequent day in the hospital. And similarly, among those who utilized the emergency department at all, SNAP participants were less likely to have repeated visits. What? And then, it's not worth it. And so based on that, based on the lower probability of admission and the expected shorter stays among those who did get admitted, and in total, we estimate, based on these cost savings estimates that you saw in previous slides, we estimate that there could be about a $2,100 savings per person per year. And this related to just nursing home and hospital utilization. And I say that because we only looked at those outcomes, but there's a lot of other potential cost savings that could be accrued due to reduced use of medications, reduced emergency department utilization, outpatient healthcare services, specialist services, and that type of thing. And even within the hospital costs, it doesn't bill necessarily for physician costs. It's just related to the cost of just being housed in the hospital and the overhead related to that. And so there's a lot of costs that we haven't captured in this, but already it suggests that there could be potential cost savings associated with it. So to summarize, we also found that among people who benefit from SNAP or who are already participating in SNAP, the greater benefit amounts are associated with reduced subsequent healthcare utilization. And as I said earlier, that is also informative to us because the last results might have been biased by that self-selection effect, right? The fact that low-income adults who participate in SNAP are just somehow inherently different from the people who don't, right? The people who participate might be somehow different in terms of the health status or resources. But among participants, we also see that higher benefit amounts are associated with reduced likelihood of being admitted to the nursing home, reduced likelihood of being admitted to the hospital, reduced likelihood of using the emergency department, and shorter stays among those who do get admitted to the nursing home and hospital. And again, the benefit amount is determined largely based on income as well as household size. And so typically the people who have the lowest income have the higher benefit amount. So those are actually the most vulnerable people. And if they have a lower risk of being admitted, then that says something about the program that's informative to us. Okay, so since we published this paper, there's actually been a more recent paper that's also come out this year that kind of validates our results. They use data from a national sample, and they use some statistical methods that naturally account for self-selection into SNAP. And SNAP participation in that study was associated with lower total healthcare expenditures of approximately, I'm pretty sure that should say $1,400 per year. I think that's a typo, sorry. It's $1,400 a year. It's more sizable than $400 a year. So they kind of validate our results in a way using national data and using total health care expenditures, not just hospital and nursing home costs. Okay, so then the question remains, why do only 42% of eligible older adults participate in SNAP? Well, I've also been working on some qualitative research among low-income older adults in Baltimore, and one comment that I consistently get in these interviews is, well, kind of two key themes. One is that low-income older adults tend to say, it's not worth it to me to enroll. It's a lot of hoops to jump through. They have to fill out the application and provide verification of their income. They typically have to have an interview. And so it's a lot of work, and they may not get a lot of benefit from it, right? The benefit amount can be relatively small. A lot of low-income older adults don't have transportation to get over to the office and apply, and they don't have internet access to do it online. So we're talking about access issues and just a lot of barriers to it. And then one other key theme that seems to come up, at least in my area of the country, is that that a lot of people feel like it's not just stigmatized, but that they're actually kind of blamed, right, for being in their position and shamed when they try to access these resources. And so one person told me, what by law I should have, they should be providing, and they shouldn't put iron gates and steel doors and insults. I mean, I wrote down a conversation I had with a social worker. She says, well, blah, blah, blah. I don't know what else she was saying. But anyway, I wrote it down, and I cried. You know, I do get to a point where you have so much of that kind of uncivilized talking. And I think that's really remarkable, right? That, and this is something that other people have told me in other ways, too, that these steel gates, the barriers that they put up, right, in terms of accessing it, and the challenges that you have to go through for enrollment is one issue, and then the shame is really another issue that then needs to be addressed in a meaningful way. And so there are some clinical implications to the results that we looked at earlier. Obviously, these results at least suggest that healthcare systems could potentially save on costs by facilitating enrollment in SNAP for eligible older adults. And it's relatively easy to screen for food insecurity. So more EHR systems are starting to do this. There actually have been several studies just within the last year that have published results, at least related to kind of feasibility and the practice of implementing food insecurity screeners into EHR systems. So there are a couple of really good questions that have been shown to reliably predict people who are food insecure just by asking a couple of quick questions. And so there is a need to better integrate these social determinants of health and screening for social determinants of health within our healthcare systems, and then integrate the care that follows that, right? So it's not enough just to ask somebody whether they're food insecure, right? But you have to kind of do something with that information. Otherwise, there's no point in asking them if you just intend to say, I'm so sorry you don't have food. Right? That's not ethical or responsible. We have to act on whatever information that a patient gives us as clinicians. And so there is a need to better integrate the social services care that should follow up that question into the existing healthcare system and resources. And then there are several policy implications. So there are some programs that have been shown to improve access to SNAP for low-income older adults. The Elderly Simplified Application Project is done in some states, where this waives the verification and recertification requirements and extends the certification period up to 3 years. So it, again, minimizes some of those barriers to enrollment that eligible older adults face, where they don't need to verify all of their income and assets, and they don't have to go for an in-person interview. So it waives some of those things. The standard medical deduction allows older adults to attain the maximum SNAP benefit if they can verify at least $35 in medical expenses, which almost every older adult can do, because Medicare doesn't pay for everything. There's always some out-of-pocket expenses. So most older adults would benefit from the standard medical deduction.
Are these all state-level programs you're describing?
Yes, yeah. So
SNAP is a
federal
program that is administered through the states in different ways in different states.
Yeah. So the income eligibility is allowed to differ by states. The enrollment process is allowed to differ by state. And so the way it actually gets implemented can actually vary dramatically from one state to the next, but these are some things that states are allowed to do. The federal program allows them to implement these programs, and so, for example, the Elderly Simplified Application Project and the Combined Application Project that I'll tell you about in a minute both have evidence to suggest that it might increase enrollment for eligible older adults. And so these are things that states can implement. And some states have implemented them. They vary across states in terms of who's implemented what.
Ohio has done none.
None of them yet.
Yeah, has done none of them. So these are all things that Ohio could do.
And what is the reason why some states don't do it? I mean, is this all money that gets paid back by the federal government? Or is it partly state funded, so the state doesn't really want to spend the extra money?
Yeah.
Go ahead.
Sorry. So I worked with Laura, someone that's working when I was at a nonprofit working with her. And yes, the benefits themselves, the food stamp benefits, are all 100% federally funded. So there's no reason from a benefit access perspective not to take advantage of some of these options. There are political reasons that, some states take advantage of a more sort of open approach to access to SNAP, and there are some state legislatures who have put constraints on their administration, their governors, on what options they can and cannot take. But for the purpose of these options that are up here, they're all things that are actually pretty popular in red states and are really done in the name of, to the point about, seniors should be accessing this program and clearly aren't. And also there's a lot of efficiencies to be found administratively in some of the simplification that comes with these options. So these particular options tend to be popular in very conservative as well as in less conservative places.
If you don't use all the dollars, if the state doesn't use all the dollars, so they have to give them.
It's not a block grant structure, so it's literally just a drawdown. So every person who is seen as eligible and is enrolled, the benefits are paid 100% federally. Caseloads overall have been going down nationally. That's largely due to the economy and some other policy changes related to younger households, but that this number for SNAP is, for seniors has been very sort of stubbornly stuck in that 40% enrolled range. And so the federal government has been more encouraging of states to try some different options and to, like these demonstration projects to try to encourage more participation.
So another project that has demonstrated ability to increase SNAP participation in South Carolina, I think is where they documented it, is the Combined Application Project. So individuals who are eligible for SSI, that's the Supplemental Security Income, are automatically eligible for SNAP. And so the Combined Application Project allows people to enroll in SNAP the time they're enrolling in SSI. So again, it kind of minimizes any barrier to SNAP enrollment, allowing them to use all the same income information that they would provide for SSI benefits. They can use that to verify their income and automatically also enroll in SNAP without needing to do an additional visit, additional application, additional verification, and all that thing. And then the fourth thing to consider is that there may be some options to improve the minimum benefit amount for low-income older adults. As I said, a lot of low-income older adults don't receive the highest, so I didn't say this, but a lot of low-income older adults don't receive the highest benefit because they're the only person in their household, and benefit amounts are distributed based on household size. And so for people with families and children, right, that's their benefit because the children can benefit from it, from the program. But for a lot of low-income older adults, they tend to live alone. And so it's a lot of work for them to get enrolled, and they're only going to receive a small benefit because it's a one-person household. And so in the state of Maryland, at least my home state now, there's a new law as of last year that uses state funds to supplement the federal funds as needed to make sure that every older adult receives at least $30 a month. And $30 a month doesn't actually go very far. It's not going to cover their full food bill, right? But at least it makes it worthwhile for low-income older adults to enroll, given the amount of... Exactly. That's kind of the reality, yeah.
Is the application good for only a year usually?
In most
There are
states.
some-
And there is an option to do 2 years for senior households, so most states take advantage of the 2 years for completion period, and then this demonstration would allow some to go all the way to 3 years. So that is, again, the intention is these are fixed income households, if they're not having a lot of change in circumstances, there's no reason to do a lot of recertification. The other thing we often say when we're encouraging older adults to take advantage of SNAP is that this benefit does roll over month to month. So if you don't go shopping this month, that $30 adds to your $30 from the next month. So, if you go once a quarter, that's a $90 benefit to work with. So does it cover your total food bill? No, but if you look at the resources, the block-granted resources that go into nutrition programs like congregate meals, home-delivered meals, other things that we think of as senior nutrition programs, in terms of just federal money coming into the program, SNAP will leave so much nutrition money on the table that if more seniors were accessing it, it would really also help all of those other nutrition programs that are trying to cover every single meal for those households. So, sometimes you'll hear like Meals on Wheels talk about this, that they say, well, we have resources to cover the equivalent of 2 weeks. If SNAP also got you 2 weeks, then you start to piece together a food for your household.
Right. Maybe I'll ask you this.
I've read that time of the month when you feel enough is associated with some kind of a meeting. And I was wondering if you had access to that there at what time of the month these people got this enough, or if everybody got enough when it at the same time. I think you adjusted to that. It might be that people in your sample perhaps all of them got enough very hungry and maybe get a meeting. The other thing is
Would you please speak louder? I'm having trouble hearing you. I'd like to hear what you have to say.
yeah, I was asking if they had access to data on what time of the month these people got SNAP, received SNAP, because I've read that the time of the month when you receive SNAP sometimes associated with the rate of admission of especially these people who receive SNAP. And I was wondering if that has been adjusted, or if they have access to that kind of information, or if for this particular population everybody gets SNAP benefit at the same time of the month.
Right.
And the other question was, looking at your qualitative findings, you found that there was stigmatization on what kind of people, like people don't want to say they get SNAP. What would be like suggestions on how to, deal with that kind of stigmatization in terms of policy suggestions?
Right. So 2 very good questions. So yes, prior studies have shown that at the end of the month in low-income households, there tends to be poor dietary quality and at least higher rates of hospitalization related to hypoglycemia specifically. So that's been true. And that's in part not just because of SNAP, but because a lot of other public benefits are distributed monthly and tend to be at the beginning of the month. So things like SSI benefits, for example, are distributed also monthly, and that's used by a lot of the very lowest income people or disabled people. And so there is some evidence of monthly fluctuations in health outcomes. It's hard to link it necessarily with SNAP, but there certainly seems to be a pattern, at least with the kind of available household income. We have not yet looked to see whether we haven't looked at kind of a granular level in our data that you're talking about of like seeing whether date of SNAP receipt is predictive of health outcomes or to look for that kind of a fluctuation in our data. We just wanted first to look and see whether, overall participation was associated with health and overall benefit amounts over the year, over the month is associated with it. But that's certainly an interesting idea question that you raised. And then the second question was, stigma, thank you. So the second question, that's a lot harder to address, right? You're talking about some cultural issues, and then you're also talking about an under-resourced system, right? Where some people, there are cultural issues where people think that low-income people are taking advantage of the system. And practically speaking, that does happen. There are some people who take advantage of the system. But it's very, very small numbers of people, right? And so it's a challenge both in terms of addressing those myths and addressing the cultural perceptions. But then it's also a matter of dealing with the system that's under-resourced and the people, the social workers and the case managers and the people, dealing with the applications who just don't have the time or resources to really truly assist people through this laborious process, right? And so in most states, the state agencies don't have a lot of resources to help people enroll in these programs. And so that by itself was a barrier, and then calls for the need for other agencies to kind of fill in the gaps sometimes in some states, and it becomes this hodgepodge of resources that are used to help people apply and go through that process. And so that's kind of like two things that could practically be at least considered or addressed. Is that a good question? Yeah.
I know. I think there's a movement too now toward delivery systems and stuff as well, which could reduce stigma because you're not, bringing it out the cart in the store.
Mm-hmm.
I had a question about, did you have any information about the quality of the foods that people are accessing in Maryland through this study? Because, some places have double-value produce perks. Or, 'cause I think in my conversations with people, I noticed that sometimes that's why they either didn't enroll or stopped using food stamps, because they felt like there wasn't a lot of access to healthier things. So I think that component might be looked at, in future studies, just to kind of gauge, because that could also, be indicative of these health outcomes that we're seeing.
Right. And also what they might be talking about behind the scenes when they say it's not worth it to enroll,
Right.
is they feel like it's not actually going to improve their ability to access the foods that they think will improve their health.
Because a lot of them are diabetic or
Right.
hypertensive, and, if you go to, certain stores and see what you can accept, you get food stamps, use them for, it's often not that preferable. It's changing, I think that.
Yeah, no, I mean, we don't know how they use the benefits. This is just administrative data, so we just know that they got the benefits, we know when they got it and how much they got it, but we don't know how they used it or how it might have improved health outcomes. That's kind of that's not a question this data set could ask, but a useful one to ask in terms of how people are using it and what are the mechanisms that actually link it, therefore, to the health outcomes that we're seeing, right? So how could it actually reduce hospital utilization? I can't answer that question with data. But maybe you have some.
Well, because that striking statistic in the beginning, too, of how, it seemed to lower certain aspects of health outcomes, even though hospitalization was reduced. So I wonder how that might, in this instance.
Yeah. No, it's a good question. It's something worth exploring. Yeah.
Does geography influence whether someone's enrolled or not?
Yes. You shook your head very quickly to that. I don't know much. I don't know a lot of specifics related to geography. I know that there are state-level differences in participation rates, but nobody's linked that, as far as I know, with state-level policies. So we said earlier that a lot of the policies are done at a state level in terms of that could improve access, but I don't know if anybody's actually looked to see whether there are state-level geographic differences that are arising because of that.
It's not only just in the state, I mean in the local, like in Cleveland, is it concentrated in certain census tracts?
It's highly
or-
correlated with poverty.
Well, just look at a red line there. Direct correlation.
Yeah, that too. Yeah.
In your data, because you can get geographic identifiers, you could look at rural, urban. I mean, I would think some of the stigma
Yes.
issues in the rural communities, so no matter, you can't hide it. If you go to the grocery store, you're going to see your neighbor, and everybody's going to talk about you. because of
Right.
that.
And there's more economic diversity in the rural and suburban areas, where in urban areas there tends to be concentrated poverty,
Yeah.
which has its own challenges. But it also means that there's very segregated communities in cities. Baltimore and Cleveland are very comparable in that way, and it means that the low-income people are shopping often in the same place, all in the same place, and the higher-income people are shopping in the same place. And so I would imagine that in cities there would be less stigma.
In the preliminary study, that this is like going way back, but in the preliminary study, we did look at we looked at the zip code in the Maryland data set and had some early hypotheses, but I think we didn't have
We
enough of
didn't
the
really
cross-association.
explore, yeah.
But this question of, in Maryland, it's a state-administered state, so there's some consistency across the state of how welfare offices run and what verification is required, things like that. Ohio, by contrast, is a county-administered state, so we have much more variation in participation levels at the county level, and, ways that policies in the office actually, encourage or discourage participation. So I would expect this data set, we would see more consistency than we might in an Ohio data set.
Yeah, that's a good point. Yeah.
So if they live in a higher income area, they're probably less likely?
If they live in a high-income area, then yes, they probably are less likely, but that's also because they're probably higher income themselves. So an individual is eligible for SNAP by virtue of their own income, and so that's the reason why we see the geographic spatial pattern. Does that make sense?
So if there is an individual who qualifies, but they happen to live in an area that's higher income, do they have less chance of enrollment?
I don't think anybody's looked at that.
Or like a mixed income, that would be interesting to look at.
I think the stigma is different in different places that you go. So, for example, there's produce distribution that we do at the food bank at the HUD subsidized building in Bay Village. When we have our SNAP outreach team there inquiring about signing folks up for SNAP, that is something that's insulting to them or not really is socially acceptable, as if we have our team out in the Collinwood neighborhood doing the same thing. So I don't know if that's where your question is going more, but I think it depends on how you're raised, or the community, things like that.
Yeah. And people's perception, it's also interesting as I do some of these qualitative interviews in terms of their ideology related to public benefits in general, right? And one woman said to me, well, I should get this benefit because I actually worked for most of my life and I paid into the system, and so I should get my money back. It's kind of like this capitalist approach to thinking about public benefits, whereas other people think about it very differently. And I would imagine that the ideology that a person has themselves might influence their approach to the benefit, in some way. But again, I don't know if there's a lot of research to back up what I just said it.
Are there any states where SNAP benefits can be used online?
I don't know of any.
Yeah,
Are there
were
pilots now?
authorized in the last farm bill, but nothing's widespread yet. There's a lot of identity verification and vendor verification.
Yeah.
And that's just sorting out. But yeah, there are a couple pilots in that.
I know of a few interventions that are using online grocery stores to address food deserts. There's one that's been done through Hopkins, through some colleagues of mine there, where the food is distributed through the libraries, and so the city health department is actually taking on that project, and so it would be a great idea. But yeah, it'd be interesting to see that. Well, I have other stuff I can talk to you about, too, but I don't want to cut off the conversation. Do you want me to bring up another topic? Or do you want to keep talking? Yeah, go ahead. Yeah, absolutely. Yeah, there's really no rush.
Just in regards to the study, and I was wondering why, if you have any hypotheses on why the risk reduction was so low with the $10 benefits. I would imagine as the amount of money increases, you would see a more dramatic improvement.
So you're surprised that the effect was as small as it was? Yeah. So, part of it is that there's actually a very restricted range of, benefit amounts, right? So our average benefit was 117, right? But there's not actually a really wide range, and so we used a $10 increment because that's kind of like a meaningful amount within that range. And if you're talking about a sample that has a lot more variability in the benefit amount, then you might be able to get, you know, a more precise estimate of the true effect of that, probably, is one kind of methodological problem. But then, so what I was surprised at, though, is that we were able to detect an effect at all, right? Because $10 for food is not a lot each month. And yet what we found was that $10, right, is associated with lower risk of lower risk of nursing home admission, lower risk of hospital admission. So it's consistently associated with a slightly reduced likelihood of all these different outcomes. And so at a population level, that would actually translate into a significant reduced health burden overall, right? So if you can even slightly reduce the likelihood of nursing home admissions, and among those, keep them out just one day less, right? Then that's actually, at a population level, a pretty good effect. And likewise, amongst those, you know, if you can keep a few people out of the nursing home, and amongst those people who do get admitted, keep them in just for a few days less, it's going to have a large effect overall. And again, these are just two outcomes, right? We haven't looked at other utilization outcomes, and we haven't looked at, say, quality of life and other things that might also be improved as a result of that are not related to healthcare utilization. So I would expect overall in terms of health burden that it probably has a greater effect than we can quantify here. Yeah.
Question just sort of at a broader level with the work. How do you see evidence like this being heard within the medical space, the healthcare space? And, you know, maybe what are the strategies to making it more palatable for, you know, broader conversations, both within healthcare and then outside?
Yeah, I mean, I think everybody in healthcare is aware that healthcare is costly and ineffective. I mean, that's a broad sweeping statement, but I think most people agree with the idea behind that statement. And so I think that what they don't know is how to do it differently. And there's so many constraints. I mean, I've been in primary care, and I know the constraints that are associated with, you know, seeing patients every 10 to 15 minutes and working patients in and seeing really, really sick, complicated patients. And trying to deal with that, and there's really no more time or space or mental energy for adding in one more issue to deal with, right? So I think what we need is a better integration of the healthcare system with the social service system. People who really are knowledgeable about this complicated enrollment process and can facilitate access in a meaningful way, help people know what they're eligible for, and be strategic about what benefits to apply for, not just SNAP, but other benefits as well. And so do have to have a more integrated healthcare system, a more expansive healthcare system, and a system that really is aware and intending to address the social determinants of health. So the Affordable Care Act was useful in some ways because it motivated these healthcare systems to be more prevention focused, because there are financial incentives for actually keeping people out of the hospital, whereas before the financial incentives always were to, like, you know, have more hospitalizations, you could generate more revenue. Whereas now there are financial incentives if hospitals are keeping patients out in their community. And so, so I think that there are, you know, we need to deal with the financial incentives and the structural factors that that cause the healthcare sector to be so, like, navel-gazing, just biomedical approach, and to think more broadly about these social determinants of health. And I think that there's a push to do that. The Institute of Medicine, just in the last year, put out a report saying that all healthcare providers should be trained in social determinants of health in their training. So nurses and physicians, for example, should actually get formal training in social determinants of health. So I think there's, like, this groundswell of people who know that we need to do something about it and are trying to figure out how to do it. Did I answer your question? Yeah. Okay. Yeah. And you had a question too. Yeah, go ahead.
I have a question about the measurement about your hospital utilization.
Mm-hmm.
So is that utilization primarily chronic disease related or just overall utilization? Because I'm thinking older adults who visit the hospital for a variety of reasons, like falling housing.
Sure.
Which I think would be less likely to be linked to SNAP benefits. So I'm just wondering, is there a breakdown for the reasons, like why they use?
We haven't yet, but we hope to. I mean, these are just two of the first papers, and we hope there will be more that we can look at specific health outcomes and subgroups. But I would say overall, so I don't know if you're familiar with the fundamental cause theory by Lincoln Phelan. It's this idea that there are these fundamental determinants of health, and SNAP is something that can address some of those fundamental determinants of health, right, in meaningful ways. These things that put people at risk for multiple different health outcomes, right? And so it could actually prevent falls, because falls are often related to well, they're related to multiple different conditions, right? It might be related to muscle wasting, it might be related to physical decline, which is closely linked with income, actually. So in other work I do that's not related to this, we see very strong associations between income and physical function in older adults. And so it's possible that increasing the income available for food would actually prevent falls. It would improve their physical function, their balance, strength, and coordination. And so it's plausible, actually, that SNAP could be associated, therefore, with lots of different health outcomes and might prevent the nursing home and hospital utilization through multiple different mechanisms. That's kind of the way of conceptualizing and thinking about it. Yeah.
So you said you're collecting a little bit of data through qualitative interviews with some of the participants, and it would be interesting to hear a bit more about their perception of the role of SNAP in their health and how I was trying to understand or think about, and started to answer this, what are the mechanisms at play that SNAP fills for these older adults in improving their health, or just slowing the health decline in these events. But do you have stories or information on their perspective of what that role is?
Yeah, no, that's a good question. I don't. I mean, with these qualitative interviews, I'm really focusing more on financial challenges, strategies they use for addressing the financial challenges and looking at with their health outcomes. So I haven't really looked I haven't drilled down yet necessarily at kind of the way that they view these resources as potentially health protective, or how they utilize them to manage their health. But it's that'll be an interesting question, yeah. I'm going to ask them now. Yeah.
Well, and along those lines, even just substitution. So to Wade's question, if you have $5,800 and you get $1,200 more, like can you now do that maybe you couldn't do when you had to use, buy food within the $5,800?
Right. So there's some evidence when they rolled out Medicare Part D, it provided an opportunity to do kind of a natural experiment asking that kind of a question. So they were able to look over time to see, because Medicare Part D improved access to prescription drugs for Medicare beneficiaries. And it reduced the cost for most people pretty dramatically. And this was not, it was a benefit that's not just available to low-income adults, but to all older adults. But what they found actually is that it did improve access to, it did reduce food insecurity, I think is one of the, and I'm fuzzy now on the specifics otherwise of that. But there, based on that study alone, there's some evidence to suggest that there is kind of this, this phenomenon where older adults kind of take money from they say, oh, well, you'll give me money for food, okay, I'll use my money for prescriptions. Or if you'll give me money for prescriptions, I'll use my money for food. And so they kind of switch money around these different parts of their life. So try to make ends meet on a month-to-month basis. And that's what you do. You kind of shift resources around from your limited resources. Yeah.
We're pretty close to time. Why don't we take, if there's one more question?
I just had a quick thing. Is there a connection with where you plan to study? Because I know, politically, there's a lot of concern over food stamp fraud, and would you study the demographics of that, or do you think that that's being studied? Because if it's some other age group that was doing food stamp fraud, that would be good for encouraging the sign up for the older Americans.
Yeah, I mean, other people have looked at food stamp fraud and found the rates are so low that it's not worth investigating that much. And of course, it's just like a bad apple phenomenon, right? There's always a bad apple in every barrel. And so we hear about that and we think about that. And I think part of the stigma is not just this like bad apple phenomenon, but people also kind of blaming, say, people with addictions, right? As like, well, why are we giving benefits to someone, say, who's on drugs, right? Or why are we giving benefits? And so it's not just this idea of fraud per se, but I think that some of the stigma also is related to our cultures, the way that our culture views people who have lived in areas of concentrated disadvantage, live in areas where there's high access to drugs. It's partly all tied up together. It's not just the fraud necessarily, but it's related to the way that we perceive certain individuals and we label them. Does that make sense? And among older adults, I would imagine that the fraud rate is very, very low because most of the people who should benefit from it are obviously not. Over 50% of the people who should benefit are not. And so we shouldn't be suspecting, of all people, we shouldn't be suspecting necessarily that fraud is an issue that's relevant to older adults.
I think that I would just say we should stay around for the next conversation because I think that this is a topic when we're talking about the political context and the rhetoric that's out right now and what the facts are to sort of understand what's myth and what's reality. I do think that everyone interested in this topic, would benefit from being more conversant and being grounded in the facts on some of this stuff. So I'm hoping that we can dive more deeply into that question in the next session.
It's a great point to end on. And
Thanks everybody for joining us again. If you didn't sign in, please do that. You can keep in touch with me, but also just so we can track ahead of it and plan forward for food and also be able to report who's coming. Again, we'll see you hopefully next month. We'll hear a panel about sterility